Hello, this is your discussion on ventricular dysrhythmias. So when we talk about ventricular dysrhythmias, the problem manifested in the ECG would usually be in the QRS complex and if not the T wave, because your QRS would represent ventricular depolarization and your T wave represents ventricular repolarization. We will be discussing three rhythms under this category. So we have your PVC, you have your VTAC, and then your VFib. Let's talk about PVC or premature ventricular contractions. So in this rhythm, okay, this is usually caused by myocardial ischemia, infarction, heart failure, tachycardia, digitalis toxicity, hypoxia, hypokalemia, and acidosis. So as you can see, there is a premature ventricular contraction, a contraction that occurred earlier, okay, than it's expected to be. So if you would look at this ECG tracing here, you have your PQRS, okay, and there is an occurrence of an early QRS complex here, hence referred to as your premature ventricular contractions. So characteristic, if you would recall the ECG shown, okay, your problem is that the ventricular and atrial rate would depend on underlying rhythm. The ventricular and atrial rhythm will be irregular. Okay, take note there is an irregularity because of the emergence of premature QRS complexes. The QRS shape in duration tends to be longer, especially on the PVC, and then the shape is bizarre and abnormal. The P wave. The P wave may be absent, and then the P to QRS ratio may have a tendency to become 0:1 and 1:1. If you would look at this normal sinus rhythm here, okay, the ratio of the P to QRS is 1:1. However, during the occurrence of your PVC or your premature ventricular contractions, a P wave could not be easily discerned. So, the patient may usually feel that they are having skip. There are different kinds of PVCs. They may be classified according to the focal point, okay? It may be referred to as unifocal or multifocal. When I say unifocal, it means that it originates from one ectopic site. When I say multifocal, it originates from different ectopic sites. It may also be classified as bigeminy or trigeminy. So when I say bigeminy, the occurrence of PVC is every other beat or every second beat, and then trigeminy, it occurs every third beat. It is referred to as couplet or paired if there are two PVCs in a row, and referred to as triplet or salvo if there are three PVCs in a row. Okay, looking at this, as previously mentioned, when I say unifocal, okay, the shape of the PVC is usually identical to one another. However, if you're talking about multifocal PVCs, you can see that the PVCs have different shapes, which would signal that there are different ectopic points for this abnormality. Then for the bigeminy and trigeminy, when I say bigeminy, it occurs every second beat, hence 1, 2, there's a PVC, first, second, PVC, first, second, PVC. Okay, and then when I say trigeminy, it occurs every third, 1, 2, this is a PVC, 1, 2, PVC. Okay, so the gemini there indicates every how many beats does your PVC occur. Then, when I say couplet, okay, couple, there's a couple of PVCs that can be seen in a row. And then when I say triplet or salvo, there are three PVCs in a row. Triplet or salvo is life-threatening because it can lead to a more complicated dysrhythmia, which is your ventricular tachycardia. Treatment. Okay, so we need to correct the underlying cause. If it is acidosis, you give your sodium bicarbonate. If it is hypokalemia, you give your potassium supplements. Then, lidocaine is given as a short-term therapy. Take note that your lidocaine is considered to be a anesthetic and used here in PVC for short-term. Then you have your amiodarone. And your amiodarone is used for frequent or persistent PVC along with your sotalol. The next ECG dysrhythmia or the next ventricular dysrhythmia is ventricular tachycardia. When we talk about ventricular tachycardia, it is characterized by 3 or more PVCs in a row occurring at a rate of 100 beats per minute. So try to recall the rate of 100 beats per minute. The causes are similar with your PVC, but your VTAC is considered to be more severe compared to your PVC. Take note that when we talk about VTAC, VTAC is considered to be a shockable rhythm, meaning you can administer a defibrillation to your patient with VTAC as long as the patient does not have a pulse. Okay, pulseless VTAC is considered to be a shockable rhythm. Characteristics: the ventricular rate is faster than that of your PVCs, so the ventricular rate is at 100 to 200. The QRS complex would be abnormal in shape. Then, the P wave is very difficult to detect. If you would look at this example here below the slide, okay, there is no discernible P wave. And then the PR interval could not be easily identified. It's very irregular because the P waves could not be even seen. And then the QRS to P or P to QRS ratio could not be determined because we do not have a P wave per se. Then, manifestations common to this patient is to become pulseless and unresponsive, meaning the patient is undergoing already cardiopulmonary or cardiac arrest. Okay, so the patient is undergoing cardiac arrest because your VTAC could not sustain life. So what are the management? Amiodarone, okay, if the patient is still stable. And then you can give other medications such as your procainamide and your sotalol. Lidocaine is again used for short-term therapy. Then, cardioversion. Okay, we do your cardioversion for monophasic VTAC in symptomatic clients. So when we say monophasic, meaning the appearance of the VTAC is almost identical to one another. Okay, if the patient is symptomatic. Okay, but then that would mean that the patient is still awake or conscious. Defibrillation is done if the patient is already pulseless and unconscious. But just like any other cardiac arrest, before you do your defibrillation, your focus is on the performance of your CPR. Okay, try to review your concepts in basic life support. Then we have your automatic implantable cardioverter defibrillator. Your AICD is used for long-term management of clients with ejection fraction of less than 35%. So again, long-term management. When we say AICD, as the term implies, implantable, meaning it is placed inside the patient's chest cavity and then it has the capacity to cardiovert and then to defibrillate. Okay, cardioversion and defibrillation are administration of shocks to the patient's heart. So in this case, the implanted device is able to deliver electrical shock going towards your heart. Then, okay, so we have your defibrillation. Defibrillation is identified to be as an asynchronous counter shock. So it is differentiated to cardioversion. When I say cardioversion, your cardioversion is a synchronous counter shock, whereas your defibrillation is considered to be an asynchronous counter shock. Okay, they depolarize the myocardium so that coordinated contractions can occur. Okay, defibrillation would depolarize the myocardium. Okay, again, to compare your cardioversion and then your defibrillation, in cardioversion, you need to be at sync. Okay, you need to be synchronized with the QRS complex or specifically the R wave. Whereas in defibrillation, this is a synchronous counter shock. Okay, you can do the shock, okay, anywhere during the ECG. Then, it is applied to attempt to terminate a non-perfusing rhythm. Okay, the purpose is to terminate a non-refusing rhythm. And again, the examples are VTAC, okay, pulseless VTAC, and then you have your ventricular fibrillation. So again, use if the patient is arrested. And the signs of arrest are pulselessness and breathlessness. Okay, so if the patient is pulseless, breathless, unconscious, you do your defibrillation. That is after you have done your one cycle of CPR or once the defibrillator is already available. Okay, so this is how you administer your defibrillation. Take note of the placement of the pads. Okay, so the one of the pads or electric pads are placed on the right upper chest of the patient and then another one on the left lower chest of the patient. So this corresponds to the apex and the base of the heart. So here, this is where your apex is. This will where the base of your heart is. So the purpose of this placement is to allow for the electrical impulses to travel throughout the heart. Now, you have two different kinds of defibrillators. You would have a monophasic and a biphasic defibrillator. Okay, common right now is the use of your biphasic defibrillator. So when I say monophasic defibrillator, the current or electricity travels from one pad to another. That alone. When I say biphasic defibrillator, the electricity travels from this pad going to this pad, and then from this pad going to this pad. Hence, it's referred to as biphasic because the direction of the electrical flow is two-way. Then you have your internal defibrillation. Okay, your internal defibrillation is usually done among patients who are undergoing cardiac surgeries. Your internal defibrillation is also the same defibrillation setup that is being used to restart the patient's heart after a cardiac surgery. Then, after your VTAC, you have your ventricular fibrillation. Okay, keyword here in your ventricular fibrillation is it is rapid and disorganized. Okay, and then there is ineffective quivering of the ventricles. There is no atrial activity evident on the ECG. So if you would compare VTAC and VFib, you can see that your VFib or ventricular fibrillation is more disorganized compared to your VTAC. Causes. So causes are coronary artery disease resulting to acute MI, okay, unsuccessfully treated VTAC, cardiomyopathy, valve problems, several pro-arrhythmic medications, okay, so meaning you have several anti-arrhythmic medications which are antagonistic to one another, acid-base electrolyte imbalances, electrical shock. Okay, the most common ECG abnormality among your patients who had electrical shock is your ventricular fibrillation. For that reason, okay, your patients who had severe electrical shock would likely have poor prognosis, usually results to death because of ventricular fibrillation. Okay, characteristics. Characteristic to this dysrhythmia is that the heart rate or the ventricular rate is at 300 beats per minute. If you would notice, this is the fastest among the ventricular rates compared to your PVC and then your VTAC. It's irregular. It has no specific pattern. And even the QRS complex could not be easily recognized. Okay, we do not know if the waves we're seeing are P waves, QRS complex, or T waves. We just see waves. Okay, manifestations, the patient will be pulseless and breathless. This is an arrest rhythm. Okay, so after you have noticed ventricular fibrillation, you need to ascertain that your patient is properly attached to the cardiac monitor, check the pulse of your patient. Once the patient is pulseless, you need to do your CPR. Okay, then treatment. So as mentioned, CPR. Okay, once you have confirmed arrest, perform your CPR right away. Defibrillation is also done because this is a shockable rhythm. And then we give your vasoactive medication such as your epinephrine. Because remember, the first drug of choice that we use in arrest is epinephrine. We may also give your vasopressin, antidysrhythmic medications, and then your amiodarone and lidocaine. Okay, so just for the purpose of comparison, okay, you can see that in PVC there is an early occurrence of a QRS complex. In your VTAC, okay, you have your P wave is not clearly be seen, then you have series of QRS complexes. Whereas in ventricular fibrillation, the P wave and the Q wave could not be easily recognized. Among the three, the fastest of the rate is your ventricular fibrillation. Again, the two shockable rhythms are your pulseless VTAC and then your ventricular fibrillation. Then we have the term ventricular asystole. So when I say ventricular asystole, this refers to flatline. This refers to the silent heart, okay? Hence the absence of electrical activity in the cardiac muscles. In other words, there is cardiac arrest. Okay, so the straight line appears on an ECG strip in your ventricular asystole. So when I say ventricular asystole, flat line. Okay, however, class, you need to be mindful that when your patient would have the flat line, you do not perceive that your patient is already dead. Okay, you need to ascertain by doing further assessment, by using the assessment of your pulse, and then by ensuring that the cardiac monitor is properly attached to your patient. Causes: VFib and loss of majority of functional cardiac muscles due to MI, and then your hyperkalemia. Characteristics: you cannot see anything. Okay, no rhythm, no heart rate, no P wave, PR, QRS complex, not visible. Okay, that's assistance. Treatment: okay, you need to activate your BLS and then your ACLS. Okay, the doctor may do intubation. However, class, again, okay, intubation is not the priority because your priority will be doing your CPR first. Then epinephrine and atropine is being given. Transcutaneous pacing is done to this patient. Okay. When we say pacing, we often use your pacemaker. So class, when I say pacemaker, it is a battery-operated generator that emit timed electric signals. The purpose of this is to trigger the contraction of the heart muscles and control the heart rate. There are different kinds of pacemaker. It could be external and temporary. It could also be internal and permanent. Okay, so class, if you can notice, your pacemaker is being implanted in the patient's chest or on the patient's chest, and then The probe, okay, or the end of your pacemaker may be located on the right atrium and then on the right ventricle. So the purpose of which is to fire electrical impulses going towards your heart. Okay, so it is used to override dysrhythmias or to generate an impulse when the heart is beating too slowly. There are different types for this one. You have your temporary and then your transcutaneous. Temporary, as the term implies, is used for emergency or elective situations, okay, that require limited or short-term pacing or need for pacemaker. Whereas your transcutaneous, despite being the best choice, okay, this is also used for long-term, okay, long-term management of your dysrhythmias. So this is a transvenous pacemaker. As you can see, it's referred to as transvenous because it passes through a major vein here. Okay, that's why it's referred to as transvenous. Okay, it inserts through your superior vena cava. This one is referred to as epicardial pacemaker because it is directed in the epicardium of the heart. Okay, so permanent. Okay, your permanent pacemaker are indicated in long-term management of symptomatic or life-threatening dysrhythmias. There are different modes of pacing. One is your fixed rate, and then the other one is your demand or standby mode. Take note that your fixed rate is asynchronous. Okay, it fires electricity at a fixed rate, regardless of the dysrhythmia experienced by the patient. Whereas your demand or standby mode would only fire electrical impulses whenever there are abnormalities detected on the P wave and then the QRS complex. So for example, if there is no P wave that was elicited, your demand or standby mode pacemaker will be able to release another electrical impulse to augment for the missing P wave. Okay, then the health teaching for those patients with pacemaker. They are not supposed to be operating on the gas-powered engines if it is not yet turned off. Objects that contain magnets should not be near the generator for more than few seconds. Okay, so that includes your phone, even your large stereo speakers, your jewelry. Okay, so it cannot be near your pacemaker. Then you have your digital cell phones. It should be 6 to 12 inches away or it should be on the opposite side of the pacemaker. It is not supposed to be carried inside your shirt pockets. Okay, areas with magnetic fields such as your MRI, such as your radio, TV transmitter, towers, lines, okay, should be far from your pacemaker because it may cause your electromagnetic interference or your EM. Then welding and use of chainsaws not recommended because of the vibratory effects. Then walk through quickly or avoid standing in near devices such as security alarms for long periods of time. Perhaps the best advice for your patient is for your patient to approach the security when your patient has a pacemaker. Okay, they might be exempted from the entrance to the security. Okay, because it may contain magnetic sensors, which are used to detect any security anomalies. Then avoid handheld screening devices, even in airports and malls, and they're advised to carry medical alert or ID band. Okay, the medical alert class should be located near their identification card, or if not, they can use your ID band. This is a common practice in first world countries, wherein that whenever they are walking around, they have an ID band that which would identify that they are at risk for dysrhythmias and that they have a pacemaker. Because class, when you will be defibrillating later on, one of your nursing interventions is to ensure that the defibrillator is not placed directly above the pacemaker. Possible nursing diagnosis for this patient: acute pain, activity intolerance, then you have anxiety and fear, risk for decreased cardiac output, ineffective tissue perfusion, risk for excess fluid volume, and then deficient knowledge. Acute pain there is caused by hypoxia. Activity intolerance is caused usually by decreased oxygen demand. Anxiety and fear is usually related to pain. The risk for decreased cardiac output would occur once heart failure ensues. And then ineffective tissue perfusion is also because of your myocardial infarction, okay, which could be caused again by decreased oxygen supply versus demand. Then risk for excess fluid volume is related to your heart failure. And then deficient knowledge is usually manifested by the uh, poor health seeking behaviors of your patient. Okay, so they might have the chest pain, they might have felt the skip beats, but their tendency is not to go to the doctor until they become severely symptomatic. Okay, those are indicators of deficient knowledge. Okay, this will be the end of your discussion on ventricular dysrhythmias. Thank you very much for your kind attention.